Hello, everybody, and welcome back to the Neurotransmitters. We are continuing into our part 2 of our Chief Concern series. I am one of your hosts, Dr. Michael Kentris, and I'm joined, as always, by Dr. Galina Geichman. Galina, how are you today?
Hey, Michael, you're getting it right. Chief Concern.
I can be taught. It just takes time.
It only took 8 episodes. Thanks for having me back. I've really loved doing this series, and I'm really excited that we've started part 2, and we're bringing back some of our fan favorites for a deeper dive.
Yes. So we are joined once again by Dr. Anand Bery, neuro-otologist extraordinaire, to continue our education on dizziness. So, Anand, how are you doing?
I'm doing well. I'm feeling good. I'm feeling grounded.
Excellent. Yes, which is especially pertinent to the subject matter for today. I love that. So, last time you walked us through a lot of the basics, and today we're going to just turn it up a notch, if you will. So, for those who have listened to our previous podcast on dizziness, because why haven't you? If you haven't, you should go back and listen to that one, and then this one. So, now that you're back, what should they be building off of as far as their next step in assessment, Anand?
Yeah, great question. So I think what I'd love to bring it back to as a bit of a refresher is the new paradigm, right? The new model that we're thinking about in assessing the dizzy patient, which is the timing and triggers model. And so, we spent in the last podcast quite a bit of time talking about how, once you've eliminated red flag symptoms, you're dealing with isolated dizziness and vertigo. One of the first questions we really should be asking is, what is the timing of symptoms, right? Is this something acute and continuous? Is this something episodic? Or is this something more on the chronic side of things? And we spent a lot of time in the last podcast talking about acute continuous dizziness and vertigo, a really important thing on the wards or in emergency room settings, really that question of trying to differentiate, stroke from an inner ear mimic. So that's acute vestibular syndrome. And then we spent some time last time talking about BPPV. So episodic conditions, but triggered episodic. So an episode comes on after a head movement relative to gravity. And so what I think we can do now, what we should do now, is go down another branch of that tree, okay? And talk about first episodic disorders that are spontaneous. So where, you're talking to the patient and you've identified that these are episodic, but there isn't a specific trigger. They just sort of come on.
Excellent.
Wait, first, can we pause and can I report back that I've now done significantly more tests with the Dix-Hallpike for BPPV than before? That was something I learned last time.
Nice.
Yes, everyone do it on every patient.
So when we talk about triggered, we're usually talking about things like movement. I guess if we want to be a little more esoteric, we could say barometric pressure or something. But these non-triggered episodes, is there no rhyme or reason to it? Any patterns that we should be looking for?
Yeah, great question. And I'm really glad that you brought that up, because really when we're saying triggered, we're really talking about head movement, thinking BPPV, or postural change, thinking orthostatic hypotension. And so some of the disorders that we're going to talk about now have other triggers. There are factors that may provoke them, factors like missing sleep, missing meals, being dehydrated. So that's not to say that spontaneous episodes, don't have any factors, any provoking factors, but it's less discretely head movement induced or sort of posturally induced. And so I think now is probably as good a time as any to talk about some of those things. What falls into that bucket in terms of spontaneous episodic disorders? And so the things that fall into that bucket, one of them is vestibular migraine. Okay. Another one is Meniere's disease. A third one that's a little bit less common, but certainly something that you always want to think about would be a TIA, so a transient ischemic attack involving the posterior fossa. So those are kind of the archetypal spontaneous episodic disorders. So migraine, Meniere's, and TIA.
A couple of these, I feel like you could invert the vestibular migraine and the Meniere's disease in as much as you always think about Meniere's and it's almost never Meniere's. and you barely ever think about vestibular migraine, and it really often could be vestibular migraine. But how do we differentiate these in terms of, I always feel like, me personally, like vestibular migraine is kind of like, well, I don't find anything else. It's episodic, not triggered. What else do I do with this, right?
Absolutely. It's the story of my life, the bane of my existence. You really got to it right away, 5 minutes in. So what I would say is that I always find it helpful to go back to the diagnostic criteria of Meniere's, because labeling something as definite Meniere's, it's actually a pretty rigid criteria, right, that you have to go through. And so, if we look at the diagnostic criteria of Meniere's, the first thing is we're looking at spontaneous episodes of vertigo, and they're really specific about the word vertigo. They really, are, again, we spent a lot of time last time talking about how we don't want to overemphasize symptom quality. But the fact that the diagnostic criteria is telling you vertigo, I think is something important to at least keep in the back of our mind. So it's spontaneous episodes of vertigo lasting 20 minutes to 12 hours. And in order for definite Meniere's, you have to see 2 of them. And then the second criteria is that we need to have audiometrically documented low to medium frequency hearing loss. And that hearing loss can be before, during, or after episodes, but it defines the ear that's affected. And so the symptoms really should be unilateral. And I will say that the classic presentation of Meniere's really is audiovestibular episodes. It's hearing loss and vertigo at the same time. So if you see that, that's where I'm really thinking Meniere's, audiometrically documented hearing loss. And then we want to see fluctuation. So, fluctuating symptoms in that affected ear. That could be fullness, that could be subjective hearing change, that could be tinnitus. And then, of course, the main caveat, which is it's not better accounted for by another vestibular diagnosis, right? They had to put that in.
Right.
But really, the audiogram is what's going to help us in Meniere's, and the strict unilateral hearing features that's going to help us in Meniere's. And so I had a mentor at Johns Hopkins, John Carey, who used to say, if the patient can point to what ear is causing the trouble, that's going to, clue us in terms of Meniere's. But really, we want to see those changes on the audiogram. Where things get more complicated is that, you heard it here first, but there's a lot of overlap phenotypically between Meniere's and migraine.
Is that a no
Something
pun
like
intended
60%.
situation?
Sure. Yeah.
I'm
right,
sorry,
exactly.
I couldn't help myself.
Yeah. I love it. So 60% of patients with Meniere's have migraine. And so many of my patients really meet the criteria for Meniere's, but they're migraineurs too. And so I really would never deny someone the opportunity to get migraine treatment if there's anything that looks like migraine. And sometimes even patients in Meniere's, we want to manage them as Meniere's, but if we're really running into trouble and there are some episodes maybe that don't have, audiometric change or hearing change, unilateral hearing change, we will sometimes treat as migraine, and sometimes we have success with that as well.
That's a great point. And again, I think we might have mentioned it last time, but I saw some meta-analysis looking at like dizziness and vertigo, and something like 20 to 30% of patients have at least 2 different etiologies for dizziness concurrently.
See that all the time.
Yeah.
I'm so glad you mentioned the overlap with vestibular migraine or migraine in general, and I hope we'll go into some of the details of that. But what I found interesting was the length of the episode, because I think that is something that I often teach to the residents, thinking about not just, sort of the prodromal, the onset, but then like what's happening once the episode is there. Is it lasting a minute? Is it lasting hours? And it sounds like they can be of a similar time frame. We're talking more hours, maybe up to a day, maybe the vestibular migraine could be a little longer. And so getting that feature that in fact that's not a distinguishing element, but it's the hearing loss that's different. So can you share a little bit more about maybe the kind of shifting to the vestibular migraine, is what's the typical length of the episode, and how often do you expect headache to accompany versus not, and other associated features?
Yeah, that's a great point. And great question. The sort of transition that I'm going to make here is to say that while I tend to be very specific when applying Meniere's criteria, I tend to be less specific about applying vestibular migraine diagnostic criteria. And I think when the when the diagnostic criteria were being developed, we were really looking for enrollment into trials. We were looking for commonality. I mean, if you think of where sort of thinking on vestibular migraine has evolved, I mean, there was a time where we didn't even think, migraine could cause vestibular symptoms in the way that it was. So we really wanted to put something out where we were being very the group was very homogenous in terms of the patients that we called vestibular migraine. But I think my one pearl would be, I think migraine, just as we see in terms of aura, thinking about before, during, after migraine. I mean, the range of things that migraine can cause. I mean, migraine's a whole brain process. And so I tend to be more inclusive in thinking about migraine. I would say the classic vestibular migraine, who's the classic vestibular migraine patient, right? It's someone who either has a history of migraine headaches themselves or strong migraine features during the episode. So that would be what you would need to make a definite diagnosis, history of migraine or other migraine features during the episode. But do we see patients who have recurrent episodes, spontaneous onset of dizziness, vertigo, who maybe don't have such a clear history of migraine headaches, and maybe the migraine features during the episode aren't as clear? I would say, all the time. And we don't want to, again, deny someone the opportunity to treat in terms of migraine. So I'm going to give a few pearls that I think are really helpful when I'm thinking about vestibular migraine. So the first is I often ask my patients about a history of motion sickness. I would say that can be really helpful because many patients with migraine, and particularly vestibular migraine, have a strong history of motion sickness. I would say there are a lot of people out there who do have motion sickness and may not have vestibular migraine, but when it's like, oh yeah, doctor, like anytime I went in the car, I was the kid on the road trip who got sick. I would never read in the car, even from when I was 5 years old. That for me is just cluing me in. Okay, this is someone who maybe has the gain turned up on processing of visual or head motion. And so maybe I'm thinking they're more on the migraine spectrum. Thinking about childhood, variants in terms of migraine, did they have sort of unexplained abdominal symptoms, tummy aches, not going to school, all that kind of stuff? Do they have a history of aura? So that's more sort of in their past history. And then with episodes, I really drill in terms of, nausea is nonspecific, that can be there with a lot of vestibular episodes, but, is there prominent sensitivity to light or sound? Like, are they really saying, I just shut off all stimuli when I'm having an episode? That's, again, a soft marker that's going to point you towards migraine. Is there sensitivity to head motion and visual motion? Because patients during a vestibular migraine episode, they don't want to move their head. They're remaining completely still. They don't want to be in a moving vehicle. Again, is it the most specific thing? I think lots of vestibular things might cause that. But if it's really strong, really prominent, that clues me in terms of migraine. And then I will say that you don't have to see headache, during a vestibular migraine episode to call it vestibular migraine. But if there is headache, and if the headache does have migraine features, or if it's followed by a headache, right, and there's headache with throbbing, nausea, sensitivity to light, that's going to, increase my pretest probability in terms of vestibular migraine.
Do you find there's a lot of overlap? I know you mentioned kind of the abdominal pain, abdominal aura, if you will. Because I do find that a lot of, again, with the few patients I've managed to diagnose over the years, a lot of times they kind of go through the whole GI rigmarole where they've had scopes and been tried on like antispasmodics and so on and so forth. How often do you see those coexisting in your experience?
It's a really good question. I don't see it as often as I think I might, and I think it has to do with the setting that I practice in, where kind of the filter to get into a vestibular clinic is much more so the dizziness, vertigo, that kind of thing. But I would say in someone who, has had a complete GI workup, whose symptoms are quite episodic, and maybe the other thing that we haven't talked about yet are triggers, right? Migraine triggers. If the symptoms seem to come on in the presence of, what are otherwise more conventional migraine triggers, that's someone who may benefit from a treatment where it's both diagnostic and therapeutic. But it's kind of funny how we're all looking at a different part of the same elephant, if you will, that certainly, there's abdominal migraine out there, maybe more in sort of children and adolescents, but I haven't seen it as much as I would think.
I know we're mostly focusing on that diagnostic algorithm, but I can't help but jump in a little bit with management. And I'm curious, for these vestibular migraine diagnoses, do you approach the treatment in a very similar way? Do you use the frontline migraine medications and counsel similarly, like use the abortive, as soon as possible, use the preventative daily based on a frequency of symptom management? I'm just curious if you, once you kind of land in this category, approach it exactly the same, or if there's nuances that you consider for management of vestibular migraine.
Yeah, 100%. It's a really, really good question. The one caveat I should probably make is that almost all of the medications that we use for vestibular migraine are off-label. And of course, this is not, medical advice, but for education. So, when I sit down and I'm having a conversation with a vestibular migraine patient, I think the first step really is to explain to them, what I'm thinking when I use the word migraine, because the way I'm using migraine differs from how we use the word migraine in our everyday life. And I really kind of explain to them, go through a handout with them that really I'm talking about migraine as a sensory gain issue, where the gain is just turned up on all kinds of sensory information, and sort of explain to them. I once had a mentor in the UK who actually wouldn't use the word migraine because it just caused too much confusion. He would stay away from using the term migraine, but really, really explaining what I'm talking about. Really big emphasis on the conservative things, sleep, really number one, stress reduction, regular meals, hydration. It's amazing sometimes what the conservative stuff can do. Where I would contrast things a little bit from migraine headaches without vestibular features is I gravitate a little bit less towards abortives. I think that's more a personal style. There are some patients who may benefit from a triptan, for example. I have had some success with that, but I tend in these patients to move a little bit more towards the daily preventive. And I will say that in the vestibular community, a lot of us tend to gravitate towards tricyclics, amitriptyline, nortriptyline. And the reason for that is they help with sleep, which is often a big trigger. They're good anti-migraine medications, and they seem to have some nice secondary effect on dizziness because they have a little bit of serotonin action. And these are patients who are at high risk of developing chronic dizziness. We'll talk a little bit about triple PD in a minute, and treatment for triple PD would be a serotonin acting medication. So TCAs tend to be used sort of a little bit more so than in migraine headaches. We have had good success with CGRP medications. There was one trial out of Jeff Sharon's group at UCSF that showed benefit. So that's a new frontier worth trying as well. So we approach it very similarly to migraine headaches, just trying to increase that threshold, that patient's migraine threshold.
Yeah, well, admit a mistake I made was that I do think about them so similarly once I've made the diagnosis. In terms of my counseling, it's like basically the same. And I have a patient who I followed for a long time. And every time they would come in, I'd be like, okay, so tell me about your headaches. They'd be like, Doc, I don't have headaches. I have dizziness. And I was like, right, you have a dizziness syndrome. We talked about this. But sometimes that was a faux pas on my part, but I do think of them so similarly in terms of the counseling about the episodes, trying to figure out what the triggers are for them, trying to do prevention, and educating them as well about potential unexpected triggers. So this particular patient was very sensitive with flying, and sort of this idea of like with the jet lag and with the transitions to just anticipate that those might be one or two bad days. And that really reassured them, just knowing that it wasn't, some unexpected thing, but something that they could plan for and deal with.
Absolutely. And along those same lines, barometric pressure is often a really strong migraine trigger. Galena, you'll appreciate this story. So when I was landing where I was going to land, or finding where I wanted to land for residency, I spent about 2 weeks out in Calgary, and it was in the winter. It was in the winter. And what happens in Calgary is they have the warm wind. They have the Chinook that comes through, and it's a major change because it's basically a high pressure system that comes in. And every day I was there, I got a migraine, with the change in pressure. And apparently this is a thing with the Chinook that folks get migraine. So I deeply empathize with my patients. It's like our heads and our ears are like little weather vanes. And just like when the weather changes, we're at high risk. So that's another big one, barometric pressure. hormone changes, obviously. Yeah.
Well, if we're gonna share personal migraine stories, then I'll quickly throw mine in. And mine is every night call. I would get visual aura, and at some point I couldn't type my notes, and I was like, I gotta go lie down.
Yep. Medical residency has a way of bringing out migraine. That's why like 80% of neurologists have migraine, because we drive ourselves there.
Oh, I don't have migraines. I just have plain old tension headaches, unfortunately.
Well, there's a type for everyone.
Right.
Great. So I think we've gone down the spontaneous episodic branch of the tree. Maybe now we can change gears a little bit and talk about more chronic disorders, chronic vestibular disorders, talk a little bit about the situation that we see a little bit more commonly in the clinic setting, in the outpatient setting, patients who maybe have entered into an everyday dizziness, or patients who have more issues with balance. Maybe dizziness is kind of a smaller symptom for them. And so the first thing that might be helpful to talk about is probably the most common disorder causing kind of a chronic dizziness, not episodic, but more days than not. And that's another mouthful, PP. And so PPPD is an acronym. It stands for persistent postural perceptual dizziness. And when I'm explaining to patients what that is, I find it helpful to go through each of the letters in the acronym to explain exactly what we're thinking about. And unlike the other disorders, the other conditions that we've talked about so far, PPPD or triple PD is more a situation, a state that patients can find themselves in, as opposed to an etiologic diagnosis. And so PPPD, again, it's a mouthful. The first P stands for persistent. And persistent, we normally take to mean present for more days than not, for about 3 months. So it doesn't have to be every day, doesn't have to be all day, but present for more days than not. To get a sense for what patients are experiencing, sometimes I'll ask them to tell me what percent of an average day they have dizziness. So to take their waking hours and just tell me, like, are you feeling dizzy 10% of your day, 50% of your day, 80% of your day? And many, but not all patients with triple PD will say 50, 70, 80% of the day, I'll be having some dizziness. So it's persistent. The second P is postural. So it tends to be worse upright. And it's not postural like orthostatic hypotension in the sense of, when they stand up, but they tend to experience it more when they're standing than when they're sitting or lying down. It tends to be worse often when patients are walking around. So when they're self-motion when upright. The third P is perceptual. So there tend to be certain environments that make the dizziness worse. So that could be going through the aisles in the supermarket. That's a classic one. Motion on a screen, self-motion, vehicular motion, so passive motion. Sometimes even a static busy environment or a static, busy scene affects them. So if one goes and looks at the original description paper by Staub and colleagues of triple PD, they actually show a hotel carpet that's really busy with a lot of jagged, lines and colors. And that's the kind of thing that would really affect patients with triple PD, being out on a street in Tokyo or New York City. So there's a perceptual quality to it. And then the last D is dizziness. So it's not a room spinning, but a dizziness, an unsteadiness, perhaps lightheadedness, not feeling connected to the ground. So that's kind of what triple PD is. Triple PD, I feel, is a state that, a lot of patients who are in having vestibular disorders that are coming on a lot could easily get into. And the way I describe it sometimes to patients is it's a little bit like that feeling that you get if you went out on the ice. Like if you were walking on the ice, what would you do? You would kind of take on a high-risk posture. You'd be a little bit more vigilant. You'd be much more careful and apprehensive. And that's kind of the state a lot of our patients with triple PD are in a month, 3 months, 5 months, a year after their initial vestibular insult. And so while helpful in the first couple of hours, that state is kind of working against them. And so our goal is to try to get them out of that fight or flight state that they might be in months or years later.
So it's I remember reading an article about PPPD a few years back, and this was I'm my own ignorance, this was the first time I had come across it. I was in a continuum review for the Neurology article like 4 or 5 years ago. It was interesting. So it sounds like some people kind of are putting it in the same family as of other functional neurologic disorders. And kind of like what you were saying, you have like all of these maladaptive behaviors, both in like the hypervigilance and the kind of like, as you said, they hold their gait in an unnatural fashion. So there's increased energy expenditure and all of these negative things that tend to come along with it, in addition to perhaps whatever their original dizziness was that may or may not be treated. And anecdotally, I find, a lot of these people have been on chronic, either like meclizine or, diazepam for, years and years. And then they finally come to you as the neurologist and you're like, oh, this is a big ball of wax I got to take apart here.
100%. I'm really glad that you brought up vestibular suppressants and suppressant overuse. I think vestibular suppressants can, they have their role. They can be helpful in the acute setting. In some cases, if someone has really, really strong symptoms from PPPD and we need to do a Dix-Hallpike, or they need to go to, PT and have multiple sessions, then we'll have them pre-medicate. I mean, they have their role in limited situations, but over the long term, they can really work against patients who have chronic dizziness. So exactly as you're saying, part of what I'm doing is just slowly tapering off those medications, explaining to the patient why we're doing that. But absolutely, yeah, I think, I think triple PD is maybe a little bit different from some of the other functional neurology that we see, in the sense that I think it's just so common among patients with, not that FND isn't common, but it's just, it's like the number one cause of chronic dizziness, because I think it's a final state that a lot of patients with vestibular disorders, end up in.
It was interesting. I think there was a motion capture study from a gait lab, if I remember correctly, right? The little ping pong balls all over them. And they were comparing the patients with 3PD to people with like bilateral vestibular neuritis, like chronic. And they had like worse gait stability and worse self-reported dizziness markers than these people who had no vestibular nerve function bilaterally, which I just thought was just wild.
Absolutely. Yeah. The functional limitation can be quite profound. And again, that discrepancy in terms of certain environments, right? Certain kinds of environments can be very tough for patients with triple PD. So I would expect patients with bilateral loss to have a lot of trouble in the dark where you're taking vision away, whereas triple PD patients are going to have a lot of trouble in a busy environment where there's a lot of motion. So if you put them in a scenario where you're asking them to walk or demonstrate balance when there's a lot of commotion, they would have more trouble there, but it can be very, very functionally limiting.
Anand, you mentioned that it's sort of like the end stage of any vestibular syndrome. So do you typically hear that part of the story, that it starts with, say, an acute vestibular syndrome or some other kind of vestibular insult, and then ends in this way? Or is there ever someone for whom like they can't pinpoint a kind of an acute episode? I've sort of seen a similar situation, and of course it can be hard to separate or parse it out like into post-concussive syndrome, because obviously then there's been like a head injury and there's dizziness as part of that, and then at one point is it stop being post-concussive and start being 3PD. But can you talk to us a little bit about that sort of, let's say, like the natural history, and is there always an initial insult that you can point to and then a follow through?
Excellent question. So I would say there are probably a few groups, and I'm really glad that you brought that up. So I would say the first group is, as you've described very well, you have a patient who had BPPV, or they had a vestibular neuritis, or they had they might have had Meniere's disease, and they have frequent episodes, and they're sort of entered the state where they have chronic daily symptoms, and they would meet the criteria for triple PD. So that's, one subset. Another subset is sort of this more vague overlap between migraine, chronic migraine, triple PD. And with those patients, the symptoms are daily or close to daily. But the way that I'll sort of try to tease it out is I'll try to ask a patient to describe what a bad day looks like, to see, do you have bad days? Like, do you have days where you just wake up or something changes and you feel worse? And often we'll be able to pick up that there might be worsening, kind of spontaneous worsening. And that worsening might have migraine triggers. It might have some migraine features with it. They might have a headache on those days. And I think there you've got this overlap between chronic migraine and triple PD, or episodic migraine, triple PD. And then I would say there's a third group where there may not as cleanly be a vestibular insult, but they're more in the triple PD category. And so, sometimes a stress event can provoke triple PD. Sometimes we just don't know what exactly triggered it, but their phenotype, matches with the triple PD. And so we treat the same. So I would say they're different groups that end up with 3PD.
So I know we skirted around and we've talked about a few different etiologies, but how do we approach the treatment? I assume it's not just, as we said, put everyone on meclizine and diazepam and call it a day. Everyone goes home happy. It's probably more complicated than that. So how do you approach the treatment for some of these specific syndromes? I know some have very specific treatments. Others are a little, let's say, more nebulous.
Yeah, it's a great question. So the first thing I always try to do is to identify anything that's addressable, treatable, sort of a perpetuating factor, if you will. And so if there's any BPPV, keep checking for it. Even on the first visit, if you don't see it, you'll be surprised how many times it's been a part of the story and we don't get that clear positional flavor. And we test them the first time and they actually didn't have it at the time that I first met them. But one day I test them and wow, they've got a BPPV. So addressing that, certainly if there's any part that's migraine, at a minimum, you want to address it conservatively, but certainly medically as well. Perhaps trying to find a medication that might address, migraine and triple PD. And then what I would say is I kind of think about the different, sides of things. So, the things that are helpful in triple PD, certainly CBT and psychotherapy and counseling can be really, really helpful, again, because of that secondary, fight or flight state. Movement. We really want to expand what a patient with triple PD is able to do slowly. Some patients are really apprehensive about head motion, really apprehensive about visual motion. And we want to, instead of having them avoid those things, which is a natural thing to do, slowly sort of move more and do a little bit more. So the movement piece, I think, is really important. I think the sleep piece is really important. We don't know, is that through a migraine mechanism? I mean, it makes intuitive sense that a lot of the connections and rewiring that's going on around vestibular input is happening when we sleep. We showed a couple years ago that patients with a triple PD tend to have sleep apnea at a much higher rate than the average population, even in patients who don't have clear risk factors in terms of neck circumference and BMI. So making sure we optimize sleep. And then from a medication standpoint, we really tend to see benefit from antidepressants. So SSRIs, SNRIs tend to help as well. And I really explain to patients that I'm not primarily using it for mood. If it helps with mood, that's a nice benefit. But I'm really using it to address the daily dizziness. So those are kind of the things in sequence that I look for. I think we've said in different ways, vestibular suppressants would try to pare those back as much as possible. Benzodiazepines try to clean things up from that perspective. Because again, what happens with those is when they're on board, they suppress the vestibular input. So they make things more manageable. But then as soon as they're off, the symptoms go way up because the problem with a lot of these disorders is that the gain on vestibular and head motion are just turned way up.
I have so many questions. I'm going to try to only do one at a time, but I guess my first one has to do with thinking about vestibular therapy for these patients. You mentioned that you want to be conservative and, that there is definitely a role for the SSRIs or another antidepressant. How do you think about vestibular therapy in the chronic setting? Is that something that still worth a shot, worth once in a while? Is it a different approach or is it less helpful when it's actually been kind of when things are more stable?
Yeah, it's a really good question. As far as vestibular physical therapy for PPD, I think there is a role, and I have seen patients benefit a lot. I think what I really like is to make sure that the physical therapist that I'm working with and I are kind of on the same page in terms of, what are we seeing on exam? What are we trying to address? Because there's different kinds of vestibular PT. And so, we wouldn't want to put a 3PD patient through, multiple Epley maneuvers, right? If we were really sure that they didn't have crystals, sure, we want to check, once every other visit to make sure. Similarly, just doing pure gaze stability that we would do for someone with unilateral loss, looking at an X and moving their head side to side. I mean, I think not necessarily the exact thing that we would want to do, but understanding where the patient's at, identifying what are they avoiding? What are they not able to do? And how could we get them there? If there are specific things that really bother them, visual things, could we in a gradual way, with the support of someone working one-on-one with them, gradually increase their tolerance? I've seen that be really helpful. So I think it really depends on the situation and, making sure that you're aligned with PT on what you think the diagnosis are, how are we going to help the patient from a function standpoint. A related question that comes up a lot is, what about migraine? What about patients who have vestibular migraine? Is PT helpful? And I think the principles are the same. Where migraine is a little bit more tricky is that, as we do PT and as we try to do habituation or try to help the patient, because again, migraineurs, it's a similar phenotype. Sometimes they can be very sensitive to head motion and visual motion. We just want to make sure that we're not, every time they go to PT, pushing them over their threshold. And so sometimes what I'll do is I'll try to increase their migraine threshold, do some conservative things, maybe get them moving a little bit more on their own, and then maybe bring up the idea of PT if they're still having a lot of difficulties with function.
Sorry about that. For the folks, we mentioned a little bit in passing, but the folks who have bilateral vestibular nerve dysfunction, whether that's because of like recurrent vestibular neuritis or some other event that have kind of a persistent dizziness, how do we manage them as far as the symptoms? Because it's like probably not something that's going to improve on its own, I would assume, at that point in time.
Yeah, great question. I think this is a great moment to kind of talk about how in a patient with chronic dizziness or imbalance, there are certain things on the exam that we want to make sure that we check carefully before we call something triple PD. Because again, patients with other disorders can have persistent, dizziness, and it can have some features of triple PD. And so I think a great one to talk about now, I'm really glad you brought it up, is the case of bilateral vestibular loss. So those are patients who have loss of vestibular function from both ears effectively. And so the things on the history that make me think about bilateral vestibular loss, well, definitely loss of balance in the dark, right? Because when we close our eyes or we're in a dark environment, we're taking vision away. So then we're dependent just on proprioception and vestibular function. And I know in other podcast episodes, for example, the gate one, you've talked a lot about, the Romberg test and the self-Romberg or the Romberg machine, aka the shower. So that, that's something.
I'd like to do some space learning here.
So we're taking vision away and we can bring out, a vestibular problem. The other thing that patients with bilateral loss will often describe is a movement of the visual world when they're walking around. So it's kind of like the Blair Witch Project, if you will, that the scene is just moving. If they're in a car on a bumpy road, they have a lot of trouble reading road signs because they've lost that inner ear input that stabilizes our gaze, that keeps our eyes steady, the vestibulo-ocular reflex. And so when I'm hearing that, I'm already thinking, I've got to check, vestibular function. And so on exam, what we would look for was we would do a head impulse test, as we talked about last time. And if we see catch-up saccades on both sides, that's going to point us towards bilateral vestibular loss. And obviously, that's something we would think a little bit differently, differently from triple PD. So if we have a patient with bilateral vestibular loss, I think it's really important to think about why and how did they get to develop bilateral loss. I think it's worth thinking about a sequential neuritis if they have a history of that. Did they have an acute vestibular syndrome and then a few months or years later have another one? It's certainly possible, more rare, but certainly possible that you can have vestibular neuritis on both sides. I would say the more common situation is more an idiopathic bilateral vestibular loss or a genetic bilateral vestibular loss. So there are now genetic conditions like Canvas syndrome, cerebellar ataxia, neuropathy, and vestibular areflexia that can cause bilateral vestibular loss. And I predict that in the next decade, we're going to identify even more genetic causes of bilateral vestibular loss. So identifying it, making sure if there's anything on the story that makes you worried about, for example, a past subarachnoid hemorrhage, because hemosiderin deposition can kind of traced down, and cause a bilateral vestibulopathy. Again, that's rare. It's usually idiopathic. Thinking about thiamine deficiency, which can sometimes cause bilateral loss, but provided you've excluded those things, often it is idiopathic. And so how do we manage the patient? These are patients who really can benefit from PT, particularly if they have decent proprioception, and their vision's good. We really want to work with them in PT to use those other modalities, to use those other senses to compensate. I always think about safety, right? So making sure that they've got night lights at home, that they're avoiding situations where they're in the dark, not taking risks from that perspective. Always want to work with PT and get PT's input in terms of gait aids. But in some of these patients, having something like a walker can be really helpful because you're adding more stronger proprioception, something to support them. But yeah, bilateral loss can be difficult.
It's really helpful to hear you talk about the role of proprioception and vision and how that's something that our brain is using to stay balanced, and then something that we can use on our history as a clue that there may be an issue. And I know we're circling back a little bit, but can you contrast that a little bit with 3PD? Do we know why those patients have such challenge with like visual input and stimuli? Is it something about that disruption between the role of vision input for balance? Or am I thinking like mechanistically, do we have any understanding?
Yeah, it's a great question. In an archetypal patient with triple PD, vestibular function is normal. Although I will say that there are a lot of patients who have a unilateral loss, maybe even bilateral loss, and they end up with a phenotype that's a lot like triple PD. So I think kind of a good way to answer your question is, what's going on in a patient who has normal bilateral vestibular function and is still experiencing triple PD. And so what we think is going on there is, it's a simplistic high-level thinking about it, but whatever happened to cause whatever happened to cause that initial insult, whether it was migraine, might have been Meniere's, might have been triple PD, force the patient to be much more visually dependent. Because that's one of the common things that we do, when we're having a BPPV. I see this all the time. Patients with BPPV are maybe having some visual motion sensitivity even in between episodes. And that's because their brain has become more visually dependent. The input that was coming in from the inner ear couldn't be trusted, if you will, and they were more visually dependent. And so for a period of time, they're more visually dependent. I think patients with triple PD have become, in a maladaptive way, much more visually dependent. And so that's why when they're in a situation where there's a lot of visual stimuli, it just overwhelms their system, right? The gain is just turned up on that visual information and they have more difficulties with balance. Their underlying vestibular function, most of them, is normal. So it's more about calibrating the gain. It's more about habituation. It's more about preventing that secondary fight or flight response from happening. So the exam can really help you out there. If they're looking like a bilateral loss patient, then the treatment is a little bit different. We want them to do a little bit more gaze stability, a little bit more sensory substitution. Although there are similarities, we want both patients to kind of use what else there is beside vision as well.
There's one entity, I'm going to go a little off script here, that we didn't talk about, but I see it thrown around, and that's cervicogenic vertigo, which I know is a little controversial of an entity. So I was wondering, do people ever come to you with that diagnosis, and what is your opinion on it as an entity?
It's a great question. Wow, you guys know how to pick the hot topics in vestibular. I'll tell you something funny. I have to, because I submitted a paper recently and we had two reviewers. One reviewer said, "Why haven't you talked about cervicogenic dizziness?" And the other reviewer said, "What is this? I thought we decided as a field that, we shouldn't be talking about cervicogenic dizziness." So what I can say, and I'll try to be diplomatic, what I can say is that there is a lot of interconnectivity between all of the afferents, that go to the neck and drive cervical proprioception and the vestibular nuclei. Like, we know that the trigeminal system and the vestibular system in the brainstem are closely wired. And you can see why why that would be important, right? They're both inputs in terms of balance. We see a lot of patients with neck tension and complaining of dizziness? Absolutely. What is the direction of that causality, right? Is it patients who are dizzy who are holding their neck tense all the time? Is it the opposite? Is it the neck tension is directly impinging on the vestibular nuclei? Or is it sort of the thing that we keep coming back to, which is, could it be that migraine is a common thread? Because we know, migraine turns up the gain on vestibular and sensory information. We also know that migraine can cause neck tension, right? It's part of the prodrome and the sort of ictus of migraine. And so when I have a patient who sort of has a lot of neck tension, I want to address it, right? I want to address the neck tension. I think they should be doing PT to strengthen their neck. They should be doing massage. If they find acupuncture helpful, I think, that can be good. We talk about ergonomics. We're all hunched over on our screens and phones. Certainly that's not helping dizziness or migraine. So I'm very kind of practical in that regard. But if someone has, any whiff of migraine, I'm not going to sort of deny the opportunity to try to treat them for that because they have a lot of neck tension. Actually, quite the opposite. I would try to think of migraine as being an underlying cause. So, cervicogenic is, it's really a description, right? It's dizziness from the neck. And so I just say, sure, like they probably do have dizziness from the neck, but what does that actually mean? And what do we actually do about that? There's a lot of active interest in this area. Perhaps we may find something, we may find specific treatments, but yeah, a lot of interconnection between cervical afferents and the trigeminal system and the vestibular system at the level of the brainstem. A lot of patients who have both, and we try to manage for both, but don't forget migraine, and certainly wouldn't deny the opportunity to treat someone as migraine. I don't find cervical imaging helpful, but of course, if there's another indication for it, that's something that you could think about. But I don't see what you would find on neck imaging that would answer this question. I think it's more a function problem than a structural problem.
I think that's beautifully said. Thank you.
So maybe now we can add one more entity that we really should be looking closely for in a patient with chronic dizziness, right? We don't want to call this a triple PD, and that's downbeat nystagmus, downbeat nystagmus. And so, we want to look carefully when we examine our patients. We want to sort of have them look in the distance. We want to add light, all the tips that we talked about last time, really advantage ourselves to pick up subtle nystagmus. And what do we see with downbeat? Well, we see a spontaneous nystagmus with a slow drift up, and then the fast phase is down. So the eyes look like they're beating down. And the things that we can do to bring out downbeat nystagmus are to bring the patient to lateral gaze. So downbeat nystagmus usually worsens in lateral gaze. So you can bring the patient to the right and to the left, and then you're looking carefully, is there a little bit of downbeat? We can remove fixation. So if we have Frenzel goggles, we can do that. Or simple trick at the bedside, cover up one eye and shine a pen light in the other eye. Credit for that to Dr. David Newman-Toker. They call that the pen light cover test. So that's a way to remove fixation. And, look carefully. Does the patient have a little bit of downbeat nystagmus? Because downbeat nystagmus localizes to the vestibulocerebellum. And that is a central, it's a cerebellar problem, and it's going to take us down a completely different path from triple PD. So we want to look carefully for downbeat nystagmus.
No, that's excellent.
Well, Anand, as proven at the start, you are an extraordinary otoneurologist who just gave us a whirlwind dizzying tour of dizziness, all the way from acute vestibular syndrome through to episodic momentary dizziness and through to chronic, whether PPPD or else. So thank you so much for this summary and tour. And it's been a exciting, wild ride. Learned a lot.
Is your head spinning yet?
Oh, yeah.
From the terminology,
neck
if nothing
and head.
else. Yeah. So if people want to find more of your work, just to remind them, where should they look for you?
Yeah, so I work at Mass Meniere and Mass General Hospital here in Boston, and I'm on faculty at Harvard Medical School. So what we'll do maybe again in the show notes is we'll share some of the other resources that I recommend in terms of starting with for all manner of dizziness and vertigo. And that'll be my calling card.
Excellent. Perfect. Galina, anything to plug for you today?
No, I think just check out the podcast episodes with Anand. They're like really good summary kind of board review. And yeah, we'll see you next time.
Yeah. No, I think everyone should continuously listen to teaching materials about dizziness. It would save me a lot of consults in the hospital. So thank you so much, as always, Dr. Anand Bery. Very much appreciated. And thank you, everyone, for listening. You can, of course, find our past work at theneurotransmitters.com. And you can find us at our various social media handles. Share the episode with a friend who you think needs to learn more about dizziness. Thanks, everybody.